Well, hello again. Thank you for joining us for our program of digital slide review and sign out. I'm Dr. Lewis Hassel, and I'm professor of pathology here at the University of Oklahoma. Our program is part of the Digital Anatomic Pathology Academy, a joint venture with Path Presenter. Each time we meet, we talk about interesting cases that may provide diversity and enrichment of your understanding about the processes in pathology and some of what they mean. Our case today comes from the realm of GYN pathology. The patient is a 67-year-old woman who's had some postmenopausal bleeding and cramping. That led to an endometrial biopsy at an outside institution, and the diagnosis from that was somewhat unusual. The diagnosis rendered was a large cell neuroendocrine carcinoma, very astutely picked up by the colleagues on the basis of neuroendocrine. And with those neuroendocrine markers being positive in a blue cell neoplasm, they made the diagnosis of a neuroendocrine carcinoma, which is quite unusual. So I just thought maybe to think first, what should we be thinking about when we see a high-grade tumor that's composed mostly of blue cells, small to medium size and so forth. And of course, neuroendocrine carcinomas are going to come to mind. The more common of these, however, are usually the endocervical type of or cervical type of small cell carcinomas. We may also see an undifferentiated endometrioid tumor have this morphology, along with various other primitive neuroectodermal tumors, some solid types of serous carcinoma, and much less frequently, rhabdomyosarcoma, Wilms tumor, other sorts of tumors of that ilk, and lymphoma. So I'd like to just take a look at the histology with you here. And this is actually from the resection specimen, which had a sort of exophytic soft tumor on the surface of the tissue. And in fact, you can see how soft it is by how easily it fragmented in the cassettes. All of this pink area here is necrosis. And so it's a very necrotic tumor, a very highly proliferative tumor. And then we see these occasional residual areas of blue cells, which are really quite poorly cohesive, clustered maybe a little bit around some of the vessels. And as we come in a little higher, I think you can see that they do tend to have some cytoplasm. There's a little bit of pink cytoplasm to these cells. And some of them have nucleoli. And they are somewhat cohesive, although they're so easily necrotic that they fall apart. And there is some karyorectic debris around as well. A little bit of azoparty effect here on the vessels, the streaming of nuclear debris or attachment of nuclear debris to those endothelial areas in that very classic azoparty effect. So not much otherwise in terms of morphologic changes, but in this situation, it is valuable to look around to make sure that there are not other elements because these tumors can frequently be admixed with other tumor components. So here we see, benign glandular inclusion, a little bit of stromal type tissue. That doesn't particularly help us one way or the other. But as we continue to look a little further, and very nicely helped by the green dots here that my trainee inserted, we see that, in fact, here we have a second component to this tumor, which is gland forming. And as we look at it, we can see that this is a high-grade serous endometrial adenocarcinoma. A lot of mitotic activity, slit-like spaces, nuclear atypia, micropapillary formations as well in this setting. So you won't be surprised then when we take a look at some of the immunohistochemistries in this lesion. So here we see the synaptophysin stain. And as you can see, the tumor is nicely positive here. We'll see that at higher magnification. But notice here in our serous carcinoma, component, this very small component, it's totally negative. So we'll come into higher magnification here, and you can be convinced that this is still our serous carcinoma elements with negative staining. And then right next door in the undifferentiated or neuroendocrine component, small cell component, very strong positivity. So different phenotype in that respect, but when we look in fact with the P53 stain, you'll see that we're getting some additional information in this process. So not surprisingly, the necrotic tissue here does not stain, but as we look at the viable residual tissue, these are all very strongly overexpressing the P53 marker. And as is expected, the same is true here in our serous carcinoma component. We can pull over there. Scrolling's taking me a little longer here. So here you can see, again, nicely overexpressed nuclear positivity in the serous carcinoma. So similar underlying mutation in both elements and differing phenotypes with respect to neuroendocrine markers and so forth. So what is large cell neuroendocrine carcinoma? What is neuroendocrine carcinomas in the endometrium? Well, these tend to occur in older patients, although they have been reported across a fairly broad range, age range. And in fact, they are quite often mixed with other morphologic types. And therefore, they tend to be a little bit under-recognized, unless as in a situation like this, they're the dominant type. Now, by definition, we'd like to see at least one neuroendocrine marker that's positive, usually synaptophysin, but CD56 can also be indicated. Now, these are often PAX8 negative, but a number have been reported to have mismatch repair defects, which is a little bit unusual for P53 mutated tumors. In our case, there were no mismatch repair defects. And so one wonders in this circumstance if, in fact, we may have a variety of mutational statuses and driver pathways that are activated or working in these tumors. Now, as would be expected, these can behave fairly aggressively. But interestingly, in the relatively few small series that have been reported, there have been some long-term survivors. One of the more recent of these was actually published from the radiology literature, where a consortium of colleagues in Japan found 22 neuroendocrine carcinomas, 6 of which were pure large cell neuroendocrine carcinomas, and detected a very significant difference in terms of survival based on stage. And notice here that in the stage 1 and 2 patients, 60+% of those patients were, out here at almost 10 years. So that's pretty encouraging that once you get past here kind of the first year and a half, 2 years, if you haven't recurred by that point, you may have a very excellent chance of survival. And of course, stage is going to be very important. The study was emphasizing the value of MRI in terms of staging. Well, so that's our case for today, an unusual endometrial carcinoma, a large cell neuroendocrine type with a minor component of serous carcinoma, both components P53 mutated. So thank you so much for joining us. If you like that case, or if you have questions, comments, feedback, suggestions, we welcome your feedback either in the comments or directly. And we do hope that you'll hit that subscribe button and catch on to future releases from our channel. So until next time, thanks so much for joining me.